So this is the Kootenai Falls. I like to start my lectures with a nice image and establish my title. This is from the northwest corner of Montana. This is outside Libby, where I grew up. There was actually a movie with Kevin Bacon that was filmed on these falls. It was called The River Wild. So this is gastric polyps and neoplasms. There are me and Dr. Hughes' two websites for USMLE questions. Like I said, they're my Twitter. I haven't posted for a while. My stuff should still be up. I need to get back to doing that. I have a very strong interest in general and organ pathology. It's actually, I went into autopsy for that reason. So I have a strong interest in it. I enjoy teaching medical students, but I'm a forensic pathologist. So I hope because of that, I have a more general perspective on it instead of getting off into the specific areas other specialists might. So please pause, read it, make sure the disclaimers do not apply to you. If they do, don't view the lectures. Same thing, pause, read the disclaimer, make sure it does not apply to you. If it does, don't read the lecture. And the last one is just my introduction, contains some stuff about my teaching style and stuff like that. If you're interested in reading that or anything, so far not very many have, but that's okay. Here are my references. I enjoy all these books. They've all been very useful. I start out each lecture with a question or two, sometimes three. And so this is a technique that makes you, the idea is that you have not viewed this material yet and that you are looking at this without the information to do it, but it makes you think about it, and then it makes you pay more attention as you watch the lecture, and it leads to better retention. So we'll go through this at the end. So we'll start with gastric polyps. So there's inflammatory or hyperplastic polyps. It says these are commonly associated with chronic gastritis, which I guess will just go along with the idea about, if you have this chronic process going on, you have increased cell production, you could easily have hyperplasia, and there's inflammation going on. It says they're most common. They have about 1 to 20% risk for dysplasia, so wide range depending on where you look at. The greater the size, the greater the risk for cancer, just like with adenomas in the colon. And then the distinction between the two is basically based upon the degree of inflammation is what it said. So they're kind of overlapping processes, and that funding gland is associated with FAP, and then also proton pump use, which is probably a good one considering how many proton pump patients are on proton pump inhibitors. I should say proton pump inhibitor use, not proton pump use. And then basically no risk for malignancy. And then gastric adenoma, these are associated with chronic gastritis and familial adenomatous polyposis as well. And they have about 30% have carcinoma. So they have a greater risk with the gastric adenoma than a lot of the colonic adenomas for harboring a malignancy. So these are just gross examples of gastric polyps. One to the right you can see is being held up, long, spindly looking, tubular. And then the left, each of the black arrows shows a small little polyp on the surface. And I can't remember specifically what these were. So inflammatory polyp, remember it says inflammatory polyp, hyperplastic polyp. There is a risk for dysplasia. Anytime there's a risk for dysplasia, there's a risk for neoplasm. And then it said the distinction between inflammation and hyperplasia is basically related on the amount of inflammation in there. I'll leave that up to the surgical pathologist. I think it's just understanding they're going to be the most common type you're going to see, and they are associated, as would be expected, with chronic gastritis, which is an inflammatory process. Funding gland polyp, you can see basically is a nodule composed of a proliferation of funding glands. This one is associated with FAP and also the proton pump inhibitor use, like omeprazole in that. And then a gastric adenoma. So you can see basically a proliferation of glands. They have some degree of dysplasia, hyperchromasia, higher NC ratios, not the normal typical mucosa appearance. And then it says these have a greater risk of harboring a neoplasm than do the corresponding colonic adenomas. Okay, gastric carcinoma. So in general, risk factors for gastric carcinoma include H. pylori. So the thing about it is anytime you have a chronic inflammatory process, you're going to have a turnover of cells. Anytime you have turnover of cells, you have division of cells, and anytime you have division of cells, increase the amount, you have a risk for dysplasia, neoplasia. So just something to always consider. It seems like a lot of chronic inflammatory processes are associated with neoplasia, and vice versa. Neoplasms oftentimes arise in the background of chronic inflammation. Any type of dietary carcinogen, obviously, and then also Epstein-Barr virus. So clinical features, you can have dyspepsia. So kind of like chest pain in that, dysphagia, difficulty swallowing, nausea, and then later, obviously, weight loss due to potentially the effects on the GI tract, not wanting to eat, and also just the caloric needs of the neoplasm itself. They can ulcerate, so you can have blood loss, so you can get anemia, and then if they ulcerate, you can get hemorrhage. There are two main types, intestinal and diffuse, which are very different morphologically, also prognostically. And then remember, as I said in our lecture, it varies a lot based upon geographic region for the intestinal type. The diffuse tends to be more consistent, but just remember that a lot of these GI neoplasms are going to vary based upon regional and worldwide and stuff like that, dietary things, because that's what they're exposed to. So if people have different diets, some people might really protect against it, some people might have it. So intestinal type and diffuse, the mutation in intestinal type is associated with the WNT signaling pathway, so APC and beta-catenin. And then with diffuse, it's associated with loss of intercellular adhesion, so CDH1, which codes for E-cadherin. So the morphology for intestinal, very characteristic. You see a mass. So you actually see an exophytic mass on the mucosal surface of the stomach. Whereas with diffuse, you don't see a mass. You just see this diffuse thickening of the wall of the stomach, which is called linitis plastica. Intestinal type has a precursor lesion, usually an adenoma, so gastric adenoma has a higher risk for malignancy than colonic adenoma, or flat dysplasia, basically not a raised lesion but a dysplastic process, which could go along with chronic gastritis or that. And then diffuse has none. So intestinal type gastric adenocarcinoma, the top left is one. So you can see the neoplasm, it's kind of darker, which could be some hemorrhage in that at the yellow arrow, and the gastric mucosa around is normal. To the right of it, you can see the bulge where the neoplasm is. Compare that to signet ring cell type or diffuse adenocarcinoma. The top left, and these are older specimens, sorry, but you see it all looks about the same. So that's the mucosa. There is no mass. But to the right of it is the cross section, and you can see this thickening of the wall of the stomach, and that's what these are characteristic of. This diffuse thickening of the wall of the stomach, but no associated mucosal mass. And the thickening wall of the stomach is what they call linitis plastica. So they're called signet ring cell because they kind of look like a ring, the nucleus at one end and this mucus within them. And even though they don't look that malignant, this is a very aggressive neoplasm. I remember one of the first cases I saw when I was on SurgePath was a signet ring cell type gastric adenocarcinoma, and these cells just infiltrated with hardly any inflammation associated with them and were very difficult to identify. So the top left shows some, the bottom right show that one you can see the black arrows. And if you look around, you can see a lot more of them, but they just have that nucleus at one end, so they kind of look like a ring, hence the name signet ring cell. This is I'm from the northwest corner of Montana. We spent a lot of time halfway between Libya and Kalispell. My aunt had a cabin. It's called the Chain of Lakes region. The lumber company donated the land to the state, and there's like 20 or 30 lakes that are just now a public park. There's some private land and stuff like that. So this is on one of them. My mom had some friends on one. We were just going around with them on the boat, and I just saw the cloud look kind of neat. So, okay, so lymphoma, you can also see these in the stomach. Most are marginal zone B-cell lymphomas. These are associated with chronic gastritis with H. pylori. Remember, there used to be a poem or something that somebody said, along the lines of, when I got gastric cancer, it was treated by resection, and now they treat it with Pepto-Bismol antibiotics and medication. And then some, though, are diffuse large B-cell, which are going to be much more aggressive. You can also see carcinoid tumors, which that was the old term, carcinoid, because carcinoid, they're cancer, but they're kind of cancer-like because they're really pretty low grade. Now the preferred is well-differentiated neuroendocrine tumors. You can also see more poorly differentiated and high-grade neuroendocrine tumors as well, too. But risk factors, the endocrine hyperplasia, you can see them in autoimmune chronic atrophic gastritis. Usually they're more around the 6th decade. They can secrete gastrin, Zollinger-Ellison syndrome, and then that secretes gastrin, which increases the risk for peptic ulcer. So you can see multiple peptic ulcers, or you can see ulcers in unusual locations. They can also produce vasoactive substances, which lead to the carcinoid syndrome, the flushing, the diarrhea, and the bronchospasm. So this is carcinoid, a low power and a higher power view. So if you look at it, it looks pretty well behaved. Each of the nuclei look fairly widely spaced. There's a lot of cytoplasm, low NC ratio. You look up close, they kind of look more like salt and peppery, speckled like that. But they, not a high mitotic rate. So they kind of look like a well-behaved neoplasm, but they are invading. So this is carcinoid tumor, now basically described as a well-differentiated neuroendocrine carcinoma. Gastrointestinal stromal tumor, or GIST. These have a characteristic cell of origin, the interstitial cell of Cajal. Hope I not pronounced that correctly. Also older patients as well. And then 75% have a gain-of-function mutation in the tyrosine kinase C KIT. 8% have in the platelet-derived growth factor receptor A. So those are just some terms. So stromal, so you can imagine it kind of looks like mesenchymal tissue, and it's going to rise in the wall. They can vary in size. The top left is a small GIST, the little white nodule in the center. The bottom right, the hemorrhagic mass that you see, that was attached to the stomach, and that was a large gastrointestinal stromal tumor. So great variation in size. And then top left, you can see the tumor at the bottom left corner, and then closer up you can see, so it's a spindly type cell, kind of looks, muscle, nerve, mesenchymal type tissue. And then it says, going along with the mutation, 95% are positive for KIT on IHC, which is immunohistochemistry. Okay, so here's a question. So pause and we'll go through it. So a pathology residence examining microscopic sections from an autopsy identifies the finding illustrated in the image. Of the following, what was the corresponding gross appearance at the autopsy? So you can see as we just went through this, the signet ring cells. And so at those, it would be the diffuse thickening of the wall of the stomach. So once again, please pause, use reflection, go back through, think of what were 5 important points that I made during the lecture. As I always say, I hope I made 5 important points during the lecture. This is a really good way to cement the material and through Make It Stick, they showed how medical students went from the bottom of their class to the top of their class using this one technique. So I used to use this in college a lot without knowing what it was called. Not as much in medical school, but I've gone back to doing this, and I think it helps me remember material, sorry, much better. So here's on, I think, the same lake, different view. I was very fortunate. I grew up in a very beautiful part of the country, and we were lucky to go out and be able to water ski, fish, everything like that and stuff. So I hope this lecture has been useful for you and has helped you learn GI pathology, and thank you.